Well, here we have an article here. Effective treatments for COVID are now available. Why are they not being used? It's from Karen Weintraub, USA Today. Go through the article here, and then I'll give my 2 cents on why I think that she completely ignores. But at the beginning of the year, it was hard to access treatments for COVID-19 because they were in high demand and supply was tight. Now treatments like Paxlovid are readily available, but not many people are benefiting because they don't know the drugs exist. There are many doses sitting on shelves not being used because of lack of education among physicians, said Daniel Griffin, an infectious disease specialist at Northwell Health in New York. It's a miracle drug. It's just not being utilized, agreed Dr. Peggy Duncan, Executive Vice President and Chief Medical Officer at Tampa General Hospital. That's largely a result of shift in the pandemic, Duncan suggests. Fewer people are falling sick today compared with the numbers of infected in December and January. So treatments aren't top of mind, she said. But yet, a lot of articles I see saying infections are rising, so we have contradictory terms thing right here, but continuing on here. Also, while specialists in hospitals were most likely to see COVID-19 patients earlier in the pandemic, primary care doctors are now on the front lines, and it's hard to educate this much larger population of doctors without available treatments, she said. Primary care doctors treat a variety of ailments with symptoms similar to COVID-19, such as allergies, so they may not immediately think their patient is infected and could benefit from early interventions. In the mixing of things they're caring for, it doesn't always rise to the top, Duncan said. Awareness varies considerably across the country depending on the effectiveness of state and local health departments' communication efforts, said Dr. Schnaffer, anti-infectious disease specialist at Vanderbilt University Medical Center in Nashville, Tennessee. Somehow the entire federal, state, and local public health structure has not anticipated the extent of education that's really necessary. They probably don't have the resources. Or there could be something else. To be effective, all treatments need to be started as soon as possible after symptoms begin, and definitely within 5 to 7 days, so there's not much time to lose. A prescription is required, so a patient must get results from a test and then see a physician before getting access to the drugs. I think that's one problem right there. We need the COVID, flu, cold aisle in your grocery store. That's going to be the biggest thing to getting rid of this. The federal government has pre-purchased the drugs, so they're available at no cost to some patients. The antiviral Paxlovid from Pfizer has shown in studies to be 90% effective at preventing hospitalization in an infected person at high risk for severe COVID-19. Hey, I'm all for that. Let's start getting that out there. I mean, this, I think it would be a lot more effective than the vaccines, personally, but continuing on here, there are other treatments for early stage disease in high risk people, including the antiviral Molnupiravir from Merck and Rickbridge Therapeutics, and the monoclonal antibiotic, that one right there from Lilly. Schaffner said he's partial to Paxlovid. The doctors in my neck of the woods would try to get you that, but as it looks like it's working the best. He said he wishes every nursing home and assisted living facility had a mechanism in place to get it to residents as soon as they test positive for viruses that cause COVID-19. Again, I'm all for that one. It's just think 2 years ago if they had even tried stuff. I heard a lot of stories where they didn't even do treatments. People got COVID and there wasn't anything until they made it to the hospital. Really too bad. Griffin says he finds it embarrassing that more doctors do not know about the treatments. I try not to get emotional, but I find it really difficult every day when I hear about a high-risk person who is being told by their providers to wait and see how they do as a window of opportunity closes for these highly effective treatments. And I've gotten emotional on that one too, because it really irritates me. We're allowing people to get more severe when they don't have to. And I do have a reading why. I'm going to tell you after I finish the article here. I think that not getting early access, I think not getting access to early treatment before the window closes is still the rule and not the exception. Those who do get access to drugs like Paxlovid tend to have more advantages, perhaps including a doctor in the family, which reinforces discrepancies seen repeatedly during the pandemic. Access to Paxlovid is not a problem in the Washington, D.C. area, said Dr. Letitia Perkins, a family physician there. I have not hesitated to write a prescription for the oral antiviral medicine and have found a pharmacy that was able to fill it. My recommendation is to contact your family physician as soon as you receive positive test result for COVID-19 to determine if you are eligible for the treatment options, especially since symptoms are typically the worst within the first 3 days. Treatment approaches change quickly during the pandemic, and primary care doctors and patients need to make the effort to educate themselves, said Dr. Camille Cotton, an infectious disease expert at Massachusetts General Hospital in Boston. It's hard to keep up on the newest recommendations, so people do need to be prepared for that. Cotton said, the information is out there. We all need to be more nimble. And the one thing that I see in this that is not mentioned, which is why I think really it's very difficult to get this treatment going. It's not education. It's not that they don't have the resources. It's right here. This is not an FDA thing. Emergency Use Authorization, EUAs. And right here it says, the FDA may authorize unapproved medical products or unapproved uses of approved medical products to be used in emergency to diagnose, treat, or prevent serious or life-threatening diseases or conditions caused by CBRN threat agents when certain criteria are met, including there are no adequate, approved, and available alternatives. And right now, the boosters for the vaccine are still under the UEAs, or the EUAs. And as long as that's going on, these treatments are going to be on the back burner. And this Karen here, none of these doctors, they don't mention this at all. And as long as that's there, and we're pushing the EUAs for the boosters and all that type of stuff, these things aren't going to be done, and people are dying because we're not doing it. Now, that's my take on it. What do you think? Does she have the better opinion? My opinion better? You just don't like the EUAs? Think they need to be gone? I don't know. Let me know what you think. Like, subscribe, comment. I'm over on Rumble, YouTube, and I'll see you next video.